Welcome to MITRExchange. I am Rachel Richelieu, the Director for Strategic Communications. Thank you for coming. We have a full house, which is great. Today's discussion is really focused on healthcare innovation for veterans. I'll go through some brief introductions and then we'll go ahead and kick off our program. First, we have Dr. Carolyn Clancy, Deputy Undersecretary for Discovery and Education at the Veterans Affairs Administration. Dr. Clancy is nationally recognized physician executive with oversight for performance, quality, safety, systems engineering, and accreditation programs. Wynn, working here for MITRE, is Vice President and Director for MITRE's Veterans Affairs portfolio. She manages our multidisciplinary teams to transform data into insights, improve the health system, and reinvent the healthcare experience for veterans. And our moderator today is Rich Byrne. Rich is our Senior Vice President for Programs and Technology. In this role, Rich is responsible for overseeing our technical workforce, our labs, our research and development capability, including our 13 technical centers. So thank you, Rich, and Dr. Clancy and Jackie for joining us, and I'll hand it over to you.
Great. So let's dive right in. Now, we've heard a major legislative act, the Mission Act, has been passed, which gives the VA an opportunity to really expand on tradition of innovation. But it is a wide open challenge. And so the question is, what are some of the ways that you can envision the VA taking advantage of the Mission Act to expand on improving the veterans' experience?
Wow, there's so much we could do, but it's a very, very exciting topic. So among other issues, the Mission Act gives us the opportunity to create a Veterans Innovation Center, or Veterans Center for Innovation. I keep getting the name confused, with a real strong focus on improved care models and improved ways of paying for care. I'm going to guess this is very common language to many of you listening, but right now, just to put this in context, when we buy care for veterans in the community, it is pretty much fee for service. Now, it makes sense at a fairly basic level that we ought to be at a minimum taking advantage of the innovations and payment models that have taken place in the private sector over the past few years. In real life, we actually don't have the authority to do that. And by the way, we're going to have to build some new capabilities. So in that context, Rich, I think that innovation is about both a new idea, a new way of doing things, a new way of skinning a cat, if you will, but it's also about making sure that we've got the capability everywhere in our system. But it builds on a long history of innovation at VA, and I think that's really, really important. Any of you who have been in a hospital or visited someone, you know, and you've got your little bracelet and they check it before they give you medicines and so forth, that came out of VA 30-odd years ago. A nurse who was not a researcher or anything like that, but she was undergoing chemotherapy, started idly wondering, how do I know that bag is mine? And that was actually where barcoding was born. And about 20 years later, the rest of the healthcare system caught up and so forth. So, I mean, that's just one of the areas. We're doing a lot of work in 3D printing. One of the areas that we're working on, which I think is a pretty profound innovation or a reapplication of something that's been around for a while, is called osteointegration. Now, anyone here who has heard of dental implants, it's pretty much the same idea. Normally, particularly if you have above-the-knee amputation, right, you've got basically a stump and we're trying to fit a prosthesis onto it. Sometimes it works okay and sometimes it works not okay at all. So last June, we had a science fair over on the Hill, and we had a veteran there who had had this procedure done. It's still investigational in this country. It's been approved in Europe and other countries. And oh my gosh, he could not wait to tell everyone and anyone, and I do mean everyone, how much this had changed his life. Because what he said was, before, when he had the usual prosthesis, every time he went out, all he was thinking about was, is this thing going to fall off, or will I look clunky, or do something weird or odd? And that's all he thought about. He had no friends, no network. He had this procedure done. Now understand, it was a hot day, but he's got very short cutoffs on, so that we can all see the point at which this prosthesis is integrated into the bone in his remaining leg. I mean, he was euphoric. I think he put "not" in front of the handicap sticker on his license plate. I mean, this was pretty amazing work. So that makes me excited, and we need it for Mission because we are transitioning from being a closed integrated system, kind of like a Kaiser, to a high-performing network. Really easy to say, a very, very different way of doing business.
Absolutely. Thank you.
Before we get started, I wanted to say, as part of CVET, we are proud that probably somewhere between 25 and 30% of our employees are veterans, so leveraging their experience. So,
And I know you've been working the Mission Act quite a bit with some of our staff, so do you see any opportunities there as well that we can think about?
I think we're doing a lot with the, Patrick's team is on the care payment models, working on leveraging what we've gotten from CAMH with Patty Steinbrecht's CAMH organization, bringing that learning over to help us as we work with the VA.
You mentioned the history and tradition of innovation, and I love the stories. Every time I hear some innovation, it's one I haven't heard before, but the ones I always hear about, the nicotine patch was done at the VA, you know, all kinds of prosthetics. The first cardiac pacemaker was VA.
First liver implant too, right?
Yes,
Transplant.
So you look at that and you say, you know, that's a tradition that's hard to keep to the level of impact you guys have been having throughout the years. You're probably one of the largest research and development in healthcare in the country, with the amount of, you know, the healthcare system and the research you do. What kind of innovations do you might guess might be coming down the line? Oh, that's a tough one to do.
I think an area we're very, very interested, inspired a lot, as in you will come to a meeting every 2 weeks in the last administration, by then Vice President Biden with his cancer moonshot, is precision oncology. There are a number of cancers for which this makes a huge difference. You know, I went to a celebration for a group that is convened to actually bring together funders and researchers for people who are studying lung cancer. And it turns out they're funding a number of people in VA, and a number of our folks are on their scientific advisory board. But I met a number of people who told me they'd been diagnosed with stage 3 or 4 lung cancer 5 or 6 years ago. As a physician, the first time I heard this, I thought, this sounds like my family, right? The right ballpark, but not exactly the right details, because in general, you're not sharing this story this many years later. But there's clearly a lot of incredibly important work going on. That doesn't mean it is at the cure stage yet, but we're have been partnering for a couple of years with the Prostate Cancer Foundation, trying to bring cutting-edge treatments to veterans with a kind of tumor which is very, very heterogeneous, right? There are some people whose tumor is extraordinarily stable, and actually VA funded a long-term study, and we funded that from my prior job, showing that for some men with very indolent tumors, it's fine to watch and wait, and they actually do just as well as having interventions. And there are some, and where some of the precision work makes a big, big difference, is in veterans with severe metastatic disease. And it's the difference between, like, this is a death sentence and weeks left, to a number of years left with a much higher quality of life.
At a recent event with Secretary Wilkie, he was saying how you guys are partnering with the NFL on the TBI, the traumatic brain injury, that there's some research going on with that as well, too, so that's kind of interesting.
Yes, in fact, I just have to brag. One of our researchers, it just so happens, was in Time's list of 50 people to watch or most influential this past year. Actually, 2 of them were, but this one in particular, Ann McKee, is from Boston and has done a lot of work with the NFL. Now, this is an area where there's been a lot of dead ends in terms of interventions or approaches that look promising, but I think they're actually making headway. No pun intended.
Well, you know, one of the challenges of the veterans is that it's in every state, every city, every rural area, and the diversity and spread of the geographically, as well as multi-generational, is probably as complex as any healthcare system. And of course, with the new technologies of mobile or telehealth, how do you see that changing some of that reach and ability to help this diverse population?
I'm so glad you asked this. I think that telehealth is a killer app for our system.
Oh, good.
Now, we don't have every last piece in place, but we do have legislation giving us the authority to do telehealth anywhere to anywhere. If you think about
State
that,
to state.
we are, well, and home to home, right? We are unbelievably space constrained in our system. 1 room per provider, period. That's it. And sometimes we're piggybacking, right? I've visited some of our clinics at 6 o'clock on a Friday, and they're still doing business because they're the second shift and so forth. So there's a lot of that. So imagine if you could relieve some of that need for space. In some of the rural areas, because about 1/3 of our veterans live in rural areas, broadband is still an issue, but we're working through a lot of partnerships for that. But one of the exciting parts is that we now have some regional tumor boards, and we're looking to scale that up. So imagine that you are a veteran in just rural Arkansas. I'm making this up, right? Now, if you lived very close to a nationally renowned cancer center, that would be great. You could go in and get your care and diagnosis there. But think about it, we've got the platform that we can share the biopsy, the slides, all the test results, and so forth. Why should you actually have to go to Mecca, so to speak, when in fact we can do a lot of this virtually? This was brought home to me because one thing I'm very, very interested in, since research is part of my group, is figuring out how do we decrease the barrier and the burden of people enrolling in clinical trials. It's a big priority for our Chief Research and Development Officer. But you know, to a large extent, people enrolling in trials relies on a light bulb moment over a doctor's brain. Oh, maybe this person would like to be in a study. Right. And then they've got to go through this tedious business of figuring out what studies and so forth. You know, if Amazon were in charge here, you know, you'd get beamed. This information would be filtered and pushed to you. And you know, what I keep telling some of the companies we've met with is, I want this to be applicable to veterans who live anywhere, because actually veterans in rural areas or pretty remote communities ought to have the same kind of access. Still a work in progress, but I believe there's literally a meeting going on at the White House about this as we speak, but I am here instead, or it's tomorrow, I forget.
That is, well, we got her above the White House. That's a good sign. We'll write that one down. That's a win.
Like my 80-year-old aunt was saying, who grew up in rural Virginia, that the doctor used to come to see her, right? They used to make house calls. So I think we're kind of going back to that with the technology, because Patrick's view is like, have a hologram that shows up.
So some work we funded at ARC, for those of you who are familiar with the re-engineered discharge, right? This was a study done with people, right? A nurse and a pharmacist called people after discharge to make sure they were doing okay, and work like a charm, randomized trial, the whole 9 yards. Literally, as the results are being announced, Boston Medical Center is laying people off because this is when the economy was headed south in a big way. So the question was, what do you do now? And what they did was to come up with a computerized interactive program with avatars. They did run into a little problem because in some hospitals, Louise, the avatar, was a little more popular than the real life nurse. When I first heard about it, I thought, oh great, I can see my father plopped in front of one of these. You know, he'll just fall asleep like he doesn't with TV. But you have to keep interacting or an alarm goes off that someone knows you're not paying attention. So I think there's a lot of value in that. But we have more home health programs. Our challenge now is going to be to pull them together in a coherent way. But we're very, very focused on how can veterans who want to choose home instead of being institutionalized, which I think is what a lot of people would prefer.
Absolutely.
And do you see that because the demographics are changing, right? So more veterans are younger, so they really want the technology to come to them versus them having to go to a medical center? Oh,
absolutely. I mean, you know, a young former Marine who works for me, what he wants is an app on his phone that tells him how's the DCVA running appointment-wise. By the way, I would like this app for other aspects of life too. We're not there yet, but we could be, and I think will be.
It's an exciting time, and one of the things that I see the VA doing a lot more is saying this is a community effort. It's a partnership-focused approach to this. And you know, the recent Innovation Week that we all enjoyed so much, and the Diffusion Council, all these activities are really making this a community effort for this innovation and veteran experience. You know, you have any thoughts about how that partnership might evolve?
Well, first of all, I think the fascination with innovation is like built into this country's ethos or our existence or something, which is a good thing. Lately, it seems to have exploded a whole lot more, which I think has a lot to do with easier access to data, protecting privacy, of course, but computing power is a whole lot cheaper. And suddenly, I've heard phrases like data is the new oil, which is kind of an interesting way to think about it. There are some challenges there, but if you think about it, we're collecting data throughout many aspects of our day. Being able to pull that together, I think, is going to be hugely important. So if you can tell from somebody's Fitbit that they're having trouble sleeping, that could be an early warning of potential suicidal ideation, or at least struggles with depression and pain and so forth.
There's so many exciting things we could ask you, but I want to open it up to the audience to let them have a chance to ask you some questions. Such a treat to have you there. I can't hog you. I have to make sure I share.
Thank you for the excellent presentation. I wanted to ask about women's care and maternity care and child care in the VA system now that the demographics are changing. There's more women in all areas, urban and rural.
For the past, I'm going to guess 10 years, 4 of our facilities have had child care centers.
Yeah.
Now, it was done as part of a pilot. Almost every facility director in our system has said they would be thrilled to pay for a child care center because it made things so much easier for the women they were serving and so forth, but we didn't have the authority. Now we do. So that is going to be happening. By and large, we provide some prenatal care, but we are referring the rest of maternal care to the community. Whether that changes in the future, I think, is going to be a matter of just volume. Right now, women veterans are about roughly 10% of the population we serve, but that's clearly going up because at the Department of Defense active duty, they're about 17%.
They're coming.
Yeah, well, so I think it's an open question for the future, for sure.
Other questions?
Hi, Patrick Curtis, Portfolio Director with MITRE here. One of the things that when we think about transforming VA in terms of the future of healthcare, it seems that the role that VA plays in terms of training so many of the clinicians around the country could be a real powerful one. Could you speak a little bit about how you envision using that role that VA has to fundamentally change the way we think of the care that we deliver for our veterans?
First of all, I think that the ability to provide a lot more virtual care, and by 2020, which is next year, our expectation system-wide is that this is not something for the interested, but actually a core requirement and competency that all clinicians have to have. And I am quite convinced that residents and other learners will be very, very interested in this. We're trying now to figure out how is it that we might involve them more in innovations and identifying best practices. Some have been there already. Usually what they did was they had a full-time employee as a sponsor. So watch this space for more of that, because I think they're really, really energetic and have a lot of great ideas. And I'm seeing that some academic centers are starting to do that and create another path for some of their residents. So great question, thank you.
Good afternoon, I'm Greg Payne, physician here in the Health Technical Center, formerly VHA Chief Policy and Planning. Dr. Clancy, can you comment on the Mission Act and the Innovation Authority you have? Any implications on your important last mission, the health preparedness mission? I know you relied on your backup to DOD, and I know they're moving to a regional, at ASPR, kind of a regional approach. I just wonder how the VA fits in with that and how innovation might play a role there.
I will just say in Puerto Rico, in terms of boots and assets on the ground, VHA played a huge, huge role. I mean, first of all, we've got a big hospital there. We were fortunate, all of our facilities can run on a generator for a week, but before we even got near that limit, some of the capacity had been restored in the city of San Juan. But we had facilities and clinics pretty much across, and a lot of people. So we could reach out to our people and figure out, you know, do you want to come to the hospital if you've got medical equipment at home that requires electricity, since it looks like it's not going to be there for a while. And we were actually able to help our other partners. It's only in the past several years, and I'm guessing that you're aware of this, that VA has really been plugged into the HHS, DHS, DOD sort of collaboration. But I think it's very, very exciting because we've got facilities, we know how to do this. We can even put people to work providing care virtually. And one of the things that we've learned in disasters, and this became a big learning from Katrina, but was very apparent during Hurricane Harvey last year, is you actually have to bring in people to backfill the folks who work there most of the time, because their lives are completely, or maybe completely shattered. Either their home's been flooded or lost, or their family members are having issues and so forth. To say they're going to be a little stressed at work is an understatement. So, you know, telehealth and virtual options can make a big difference there. And I think we've learned how to do that more efficiently rather than figuring out, do we have to wait for them to declare an emergency to make sure these people are credentialed and so forth. So that part is fun.
Hi, I'm Bob Darnell. I'm a physician scientist at Rockefeller University and a senior fellow here at MITRE. I really appreciate you bringing up the moonshot, which is exciting. And I wonder, you know, it's both wonderful to hear the examples about lung cancer and prostate, because I totally agree with you. At the same time, all of biology is potentially at some cusp of turning here. And I'm interested in your thoughts about the MVP itself or other initiatives that might be able to scale and think about transforming healthcare in that dimension of big data.
First of all, I think that many of you know this, but just if not to belabor the obvious for a moment, the Million Veteran Program, or MVP, an amazing program which is really a partnership with the veterans who are in it. We're at about 750 or 775,000, so we will make 1 million for sure. And which makes us not only one of the largest repositories of genomic information, but also the unique repository that also has clinical electronic data. Possibly not for all of their care, because some veterans go to other sources for their care on their own with their own insurance, but a huge, huge asset. Until recently, until the price of sequencing started to drop, right? We were still struggling with where do you find the resources for this. What we're looking at now and we'll be moving forward on is being part of the Data Commons, hosted out of the University of Chicago. Roughly the first 500,000 veterans enrolled in this were enrolled under one kind of consent that more or less said the people in VA can use this, but not just kind of everybody. Since then, we're also part of the All of Us initiative at NIH. So I think there's a lot of exciting developments. And we're trying to figure out, I mean, what's fascinating about this, and I love, but it's not so easy to execute or implement consistently, this really starts to blur the lines between research and management, right? You know, what we do now is we fund research and then we try to partner with people who are in charge of operations. And sometimes we even try to move upstream with that, although that's sometimes works well, sometimes not so much. But this is like real-time fluidity, if you will, or blurred boundaries, which is both exciting, but it's going to be interesting to navigate as well.
It's very exciting to see personalized medicine on the cusp, and so no better than the veterans should lead the way because of that combination of data that is uniquely yours. I think we have time for another question or two. Do we have another one?
Hi, my name is Ann Gauthier, and I've had the pleasure of working with you much in our past. I'm with the Health FFRDC here in MITRE. We've talked a lot about new advances in biomedical research and in medical research here. I was wondering, in this new world, if you saw any opportunities to partner with the Innovation Center at CMS for new kinds of payment models or and delivery models that come from that.
I think there is in a couple of different ways. What I would love is for us to be partnering with them from the get-go, and I think with the job that I currently have since this past July, there could be some amazing opportunities with some of our academic affiliates, some portions of VA, coming in together under CMMI and so forth. At a minimum, we want to be able to have access to their successful innovations. But again, that's going to require some new capabilities on our part. So just to give you a concrete example, recently I visited a new medical school, and it's very, very exciting, and they're doing great work in bundled payments. And we have a multi-specialty clinic right nearby. So they'd like to sell us hip and knee replacements. We'd probably like to buy them. Now, first we're going to have to get that approved as a pilot under this new center because we don't have the authority now. We would clearly have to train people how to do this. In between the lines, though, I think they want to sell us more than that. And we may or may not want to buy a bigger package, right? So we're going to need people on our side who know how to negotiate. This has not been a standard PD in the Veterans Health Administration, so we're going to have to work through those issues. I don't think they're insurmountable, but new ways of doing business.
Hi, Dr. Clancy. My name's Christina Sheridan. I'm with the CVET program and also a patient engagement researcher here at MITRE. My question for you is around the veterans' whole health and the focus on maintaining health of veterans so they don't require health care services potentially, and the importance of social determinants of health in that. Could you speak to how the VA are addressing that as well?
As a famous researcher, Carr White, once said, patients have problems and medical schools have departments. And sometimes large, complex healthcare organizations feel like that as well. And If you think about the morbidities facing the U.S. population, including veterans, I mean, chronic illness is a very, very big part of that. Layered on that, of course, is the behavioral and mental health issues that many veterans have experienced as a result of, or at least exacerbated by their time in service. So a whole lot of this is about the whole notion of setting your own personal goals. And I have to say it's been pretty amazing. So right now what we're doing is across our 18 networks, each one has a flagship facility. And it's been quite remarkable and inspiring to our employees as well as family members of veterans, which a very, very strong focus on resilience and you're in charge. And a lot of it is also ends up being very much entwined with issues related to pain management. So there's a very strong relationship with integrative and complementary interventions, which we now have coded across our system, which has been a challenge. But more to the point, the notion that, you know, this is my life and my new mission is about what path am I choosing and how do I do a great job that way. So we're still learning a lot about, are we identifying the right people? And in classical medical care, you would say targeting, but that may not be the right word here. And which components of this intervention are effective and so forth. But I have to say, it's pretty inspiring.
Just going back for a moment to the Mission Act, one of the challenges that it specifies is relooking again and again each 4 years or so at the capacity versus the demand. And I wonder if you could share, if you have thoughts around how the academic affiliations that are now part of your responsibility might have a role to play in terms of complementing and providing some of that community care and maybe offsetting some of the demands on the VA network, basically.
You know, we've been working with the Congress on this legislation for probably a year and a half before it passed. In part because it builds on the earlier law that gave us the choice program. And I think if we had one shared goal, completely bipartisan, it was not to re-experience some of the same adventures with the bill that was put together in an unbelievably short period of time. Throughout this is the notion that where it's relevant, we have sort of preferred partners in the community, if you will, and that would be our longstanding relationships with academic affiliates. I mean, we're talking 70 plus years now. That doesn't necessarily mean that, depending where you are, that they're necessarily going to have all the capabilities that we need. And some of them have struggled with choice, for example. They weren't all that happy with that, and I don't blame them. And as well as other federal partners, whether that's in some cases the Indian Health Service or community health centers and so forth. I think there's going to be a lot of opportunities. There's a thorny set of interesting legal issues about sharing space that we're working through right now. And you know, this is one of those challenges where you keep hitting brick walls and then there's an opening and we think we're done and
another brick wall.
We're not, exactly, yes. So we're still working through that, but I think there's a huge amount of interest in figuring out how do we do that. Because after all, they're going to have the same kinds of challenges, right? So much of healthcare is moving out of hospitals to ambulatory care settings. That I think is going to be the most fascinating dynamic of all of this. Not fascinating enough to necessarily overcome a sense of, but that's my VA and I want that building here, but healthcare is changing a lot.
Well, I want to close, but first I have to thank you, Dr.
you.
Clancy, for your generous time. And then now you're in trouble with the White House, so we feel a little guilty about that. But on the other hand, I want you to know it was for a good cause, because everybody in this room, in fact, everybody in the company, stands ready to support you, not just in your role, but in really helping the veterans experience and get the best health care they deserve. So thank you very much, and we look forward to supporting you in the future.
Thanks so much.